Ladies and gentlemen, thank you for your patience in holding. We now have our speakers in conference. Please be aware that each of your lines is in a listen-only mode. At the conclusion of our speakers' presentations, we will open the floor for questions. Instructions will be given at that time on the procedure to follow if you would like to ask a question. It is now my pleasure to turn this conference over to Chris Hund. You may begin.
Thanks, Chantel. Hi, everybody. This is Chris Hund. I'm the Senior Program Manager in charge of the TeamSTEPPS National Implementation Project. And I'd like to thank you all for joining us today for our April web conference on TeamSTEPPS. This is TeamSTEPPS for Learners, and it's focusing in on TeamSTEPPS in interprofessional education and other educational settings. I think oftentimes when we think about TeamSTEPPS, we think immediately about going to a master training course and running home and trying to do implementation and all of those types of stumbling blocks. But this is a very important perspective as well when we think about addressing learners and addressing people in different levels of their educational experience as they become clinicians and also continue in their education after they've already become clinicians. I'd like to thank, as always, the Agency for Healthcare Research and Quality, who funds all of this work, and especially Jim Battles, who is the main sponsor and the main director of this project for AHRQ. I'd also like to thank Heidi King, who is in charge of this work from the Department of Defense standpoint. The DoD has always been extremely important in TeamSTEPPS work and is actually where the real genesis of this work came from back in the 1990s. The project team itself, the project is run by the Health Research and Educational Trust. That's where I'm from, and we're a part of the American Hospital Association. I'd also like to thank our partners in crime in all of this, Impact International, who does an extreme amount of work with us on subject matter and evaluation and general support for our TeamSTEPPS online portal and all of these webinars. Just our quick, at the start of these webinars, we always like to remind everybody about our TeamSTEPPS master training courses. We do 2-day training courses. That's a train-the-trainer approach so that you can go back to your hospital and teach others about TeamSTEPPS and help implement TeamSTEPPS in your hospitals. So these courses we find very important, not just because it's good to come and learn something in person and talk to your peers, but also because the people who run these centers across the country, excuse me, are really people that we consider the highest experts in TeamSTEPPS. They've been doing it for a long time. They all have different perspectives, and we're really happy that the director of one of these centers, Dr. Karyn Baum, is our presenter today. We know that there are a lot of people on waiting lists right now for these trainings, and we're looking for solutions to that right now, and so keep your eyes peeled. We'll be definitely sending some more information out to you soon about some other training options and possibly other locations for trainings. So very shortly, we hope to have some solutions to the waitlist problem. I mentioned the TeamSTEPPS portal before. I think you all know about it because that's probably how you found out about this webinar. But it's www.teamstepsportal.org, and it's growing. Every day we keep trying to post new tools and resources and to also do some work along the lines of getting people to submit implementation stories and working with them to craft a story that we could then post online to share with others about what's going on at hospitals around the country. We also have some discussion forums, and these are specifically very helpful for people who've attended the trainings because we have site-specific discussion forums so that you can speak to your classmates that were at the training. We also have a main discussion forum that anybody's free to post a question on or put feedback on or post an idea. coming, we have the 7th Annual National Conference. We're going to be in Dallas, Texas this year, and the dates are June 12th through 13th, and there is going to be a whole different program compared to previous year's national conferences. And the reason for this being is that we really opened it up to the community this year. This is an entirely community-sourced conference. Everybody submitted abstracts that's going to be presenting. And so if you've been to the conference before and thought, you don't need to go again, it's probably going to be similar people presenting, I could be honest with you that I think there's under 10% of similar people who presented in the past. So it's exciting to be getting people from the community, and to register for it, go over to the website and click on the National Conference tab. And I have to tell you that we're getting down to the nitty-gritty. We probably have, well, definitely under 20% of the slots are remaining. So please go and sign up if you're interested in signing up for the conference. We'll be able to post the agenda for the conference really soon now, too, as we've finalized all of the panels. So you'll be seeing that come up in the portal and also in email communications to you if you're on our lists. Anytime you have a question, you can feel free to call the helpline. There's the phone number. It's also posted on the TeamSTEPPS portal, and we'll be able to get back to you within a couple of days. We try to do it much faster, and any types of questions you have, be it about the national trainings centers, the national conference, the portal, even technical support questions. If we can't answer the phone, if we can't answer your question when we answer the phone, we'll definitely get you somebody who can answer that question for you. Another great way is to email us, and there's the email address that's also on the website. Just some rules of engagement about today. You'll see on your screen the discussion area, which is a little chat area. We encourage you to write questions in there during the entire web conference as you think of them. We'll answer if there are any technical support type questions right away. Someone will help you out. If it's a question that's more about the content of what Dr. Baum's presenting, what we'll do is we'll kind of look at those, group those, and ask those questions at the end of her presentation so that we could start the discussion that way. Then when we're finished going through those questions, we'll open up the phone lines to have a Q&A if anybody wants to ask their question verbally and doesn't want to write it out. And then we also have some extra questions for discussion at the end that we'll bring up just to spark conversation. So that's how we're going to go about doing this today. Okay, so now what the whole purpose of this today is and what you've been waiting for is Dr. Karyn Baum from the Minnesota TeamSTEPPS Training Center. She's a professor of medicine and is also the associate chair of clinical improvement at the Department of Medicine. And Dr. Baum's really been here from the start. She's been involved with TeamSTEPPS from the beginning of the national implementation, and the Minnesota Center has probably, I don't know the numbers, but hundreds of master trainers have come out of that center. So I'm very happy that she gets to present. And Dr. Baum, I'd like to turn it over to you right now.
Thanks very much, Chris. First of all, if there's any problems hearing me, please let me know, or type it into the discussion area. And as Chris has said, I've been the director of the Minnesota Center since the beginning of the national implementation. I also work at the University of Minnesota Medical School and have experience teaching this with medical students, in an interprofessional setting as well, and then also with residents and fellows and faculty. This is meant to leave a lot of time for questions, so hopefully we'll be able to spend quite a bit of time in Q&A. But certainly as you think of things, please write them down or send them in so that we can also spend a little time learning from each other. And thank you for taking time in the middle of your day. So the goals of this webinar are to just talk about why we should integrate team training into education, as well as to review some best practices for integrating team training and specifically TeamSTEPPS. Also to go through some of the adjustments to the curriculum that do need to be at least considered when using this with learners. And by learners, I mean people who don't have their, formal practicing license. I recognize that we're all learners, but in this case, I mean folks that have not gotten their license or their terminal degree yet. And then also just to spend a little time, because I think this is always a challenge, it's certainly a challenge for me, talking about challenges specifically in the interprofessional setting. So when there's medical students, nursing students, pharmacy students, health admin students, et cetera, et cetera. So I think we all need to think about why we want to do this. Well, on the face of it, it seems wonderful, but many of us suffer from curriculum bloat. Things are added to the curriculum, but nothing ever seems to leave the curriculum in most of our cases. So whenever considering whether you need to add something, it really does need to be added for a thoughtful reason. In this particular case, this is the reality for most of our students. They will be practicing in teams. It is the new paradigm for care delivery. For those of you on the line who are in practice now, I would challenge you to think of a time where you ever practiced totally alone. And I'm a hospitalist and a practicing hospitalist, and I can't think of a time I ever walked in the hospital or when I did clinic, ever walked in the clinic and practiced on my own. If somebody wasn't there to help me, the patients wouldn't be cared for. I can't even get into the locked Pyxis room. They don't give the doctors the opportunity to even reach the medications, and probably for good reason. The other reason to do this is professionalism, and I think for many of us this has been the biggest reason to start teaching teamwork. We've all been challenged with a changing face for our different professions, and a challenge teaching our learners how to be as professional as they can be. And the other reason to do this, which is the reason to teach TeamSTEPPS, is that there are benefits. There are benefits to the patient and the family. There's benefits to the team, and there's benefits to society. If people can graduate ready to practice in this new environment, then we can get them up to speed much more quickly on the other aspects of their job, which is hard enough as it is. So I'm from Minnesota, so very important to have a quote from Mayo. But note the date of this quote, June 15th, 1910, so over 100 years ago. The sum total of medical knowledge is now so great and widespread that it would be futile for one person to attempt to acquire, or for any one person to assume that they have even a good working knowledge of any large part of the whole. The very necessities of care are driving practitioners into cooperation. The best interest of the patient is the only interest to be considered, and in order that the sick may have the benefit of advancing knowledge, union of forces is necessary. This always reminds me a little bit of going to battle, union of forces. But it is these days, especially in our very complex care environments. We cannot take care of the patient without working as an interprofessional team but yet our learners spend their whole lives separated. And for those of you that have been trained at Minnesota, you've heard me say this. At Minnesota, everything's connected by tunnels. And it literally took me 5 years of being a faculty member to realize that simply down the hall and around the corner was where I could get to the School of Nursing and the College of Pharmacy. And it's those silos that we have to break down. And we come to the field, as it were, with so many assumptions. So having students learn together when they're students can really change the culture much more quickly than all the trainings of frontline staff. The Institute of Medicine, many of you have seen this, I would imagine, is well aware that team training is important. Once in practice, health professionals are asked to work in teams, but they're not educated together or trained together. And yet we're all surprised that they don't know how to work together. Of course they don't know how to work together. They don't know anything about each other. We looked at this when we started our teamwork course, and it was actually amazing how many assumptions there were about what the other professional students did. Some of those assumptions were positive. Many of them were not so positive. So the other reason to do this lately, and this is just one example, and I did not want to pull examples from every profession, but you can find them from nearly every health profession at this point, is that increasingly those that accredit our schools are pushing this as an agenda item for good reason. So for those of you in medical education, especially in graduate medical education or GME, they are putting out these items called milestones. These are some of the internal medicine milestones. There are 16 activities that they consider that constitute the core of the profession. 4 of them directly have to do with teamwork and interprofessional teamwork at that. That they lead and work within interprofessional teams, they facilitate the learning of patients and families and members of the team, that they enhance patient safety, and that they improve the quality of care both at the individual and the systems level. And increasingly, there will be site visits for every program every site that has a GME program to make sure that they are actually teaching this, evaluating this, and making sure that residents are involved in a meaningful way in patient safety, quality improvement, and teamwork. So again, that's 4 out of 16. That's 25% of what internal medicine felt constituted the core of their profession. That's fairly impressive. Pediatrics has also come out with milestones recently, and again, teamwork is called out over and over again. Each one of the GME programs will have milestones published shortly. I don't think a single one will go without at least one milestone calling out teamwork. So this is something that, increasingly the expectation is that we deliver this education and that we also can conclude that they actually received it and that they're actually competent before they practice. For nursing, and again, I just wanted to call out a specific example, nursing has been working on improving quality and safety education for nurses for several years now. For any of you who haven't gone to the QSEN Institute website, I would strongly encourage that you do so. They have spent years developing competencies, teaching strategies, videos, there are resources, and again, specifically called out over and over again is teamwork and team training, that we cannot work alone, we have to work together. So also, fairly excitingly, interestingly enough, The groups that accredit many of the healthcare organizations, the teaching organizations, are all located within the Beltway in D.C., but until a few years ago, they didn't talk to each other. A few years ago, they did come to the realization that if they all believed in interprofessional education and collaboration, they needed to lead the way, and they did. So AACN for nursing, AACP for pharmacy, dental, medicine, public health, they are all meeting on a regular basis now to take a look at what are the similarities, what are the team-based competencies. They took a look at what they felt was core to all of these professions across these professions and came up with 4 domains: values and ethics, roles and responsibilities, which means knowing not only your own but each other's, interprofessional communication, and teams and teamwork. And although you could argue that interprofessional communication is part of teams and teamwork, they called it out separately. They then developed an extra document looking specifically at the team-based competencies, and they specifically mentioned TeamSTEPPS as a best practice. These documents are available online as PDFs. If you simply Google the Interprofessional Education Collaborative, you can get both of these very easily. To be honest, the miraculous thing was that they actually published it. The ideas contained in them are ideas that will sound familiar to anybody who's trained in TeamSTEPPS or teamwork. But the fact that these organizations banded together and made this consensus statement is really helpful, especially if you're trying to go to your leadership and make the case for something else being added to your curriculum. Because again, we all know how hard that is. So I talked a little bit about why this needs to be added to the curriculum. I wanted to give a couple of specific examples, not to say that these are the only way or the best way, but again, just to give some specific examples of how this has been done. And I'm sure many of you on the line may have examples as well, and I think that would be an interesting thing to hear later is, you know, if any of you have started with this. So this is an internal medicine resident clinic, so it's a teaching clinic. And this gets to the idea that sometimes our learners are also within our frontline staff. So the clinic had some challenges. They had low patient satisfaction scores. If you talked to people within the clinic, they would tell you confidentially that the clinic was not very functional. And the clinic director really, when she took a look overall, did not feel there was a culture of safety. So they felt that TeamSTEPPS could help address these issues. The decision was to train the entire clinic, including the residents, in TeamSTEPPS. This was accomplished through a 90-minute training session, which was largely didactic with interactive exercises. No simulation, high-fidelity simulation was used. In order to do this, we used heavily edited TeamSTEPPS slides, taking those full slides from that day one and heavily editing them down, one, to get it done in 90 minutes, but also two, to focus on certain areas more than others. You know, it was felt to be important to focus more on certain issues, certain skills within that TeamSTEPPS skill set. So there was an evaluation. There was a pre- and post-test of knowledge, and that did improve. The culture also has improved, as has scheduling, which was one of their issues. They felt like because the communication wasn't as well as it could be, there were challenges with scheduling. Some of the lessons learned were that this dovetails very nicely with the concept of medical home, and I'm sure many of you are working on, PCMH accreditation. And actually, this clinic did go on to apply for and receive that designation. The other lesson was, if you train your frontline staff and there are learners within the environment, they need to be included, and vice versa. To simply have trained the learners but not to have included the other frontline staff or the faculty within the clinic may not have led to the results that they received. The other thing that they did was they put their money where their mouth was. So they actually, because it was a 90-minute session, we did 2 in a row. We shut down clinic for half a day. That sends a significant message to those coming about the value placed on this. Also, it was mandatory. People were informed in advance. A date was chosen where there really were just a very small number of people who were away that specific day. Arrangements were made for those people to have a secondary training a week later. People had to sign in. And it truly was mandatory. If you did not receive training, you had to do something else. So in other words, something bad happened to you if you didn't do it, which also sends the message that leadership truly values this. I think they ended up, I don't believe they got to 100%, but I believe they got very, very close to 100% being trained within the clinic. So that's one example which included sort of graduate learners, so people in a clinical setting. And the same would work if this is senior nursing students who are within their clinical rotations. So there's also times, however, that we want to teach this to people who have very little to no clinical experience. So this is one specific example. This was medical students and nursing students. They had some very specific objectives for their session. They wanted them to recognize the effects of medical errors. Students at this level of training may not even realize that they are seeing an error as it happens. They wanted them to be able to use some specific strategies, use some specific skills, and they wanted them to be able to put into practice those skills in a simulated clinical environment. So in this particular case, there was simulation. So this was a half-day workshop, just in terms of the logistics of it. This was all first-year nursing students and all third-year medical students. So at this point, the nursing students would have had a small amount of clinical training. The third-year medical students, this was right at their transition. I don't believe they had really had any clinical training at this point. So what was done for them? They had a large group lecture, then small group sessions, and then they also came back together and had a summary session as a large group. And they used TeamSTEPPS to help create the curriculum, as well as the language was used throughout. So again, they had a background on quality and safety and the effects of medical errors, and this is one of those challenges of working with learners. Unlike those of us in practice, they may have not considered the effect of medical errors, and many learners are still at the point where they believe that errors only happen to bad fill-in-the-blank, doctors, nurses, pharmacists, physiotherapists, etc. So, learners, especially early in their careers, need a little bit of that education. And then they did have a lecture on specific TeamSTEPPS strategies. They were then broken up into small groups, as I said, which had both, medical and nursing students. It also had both medical and nursing facilitators. They went through an icebreaker. They had videos and case discussions using TeamSTEPPS, which is another nice way to essentially give the learners clinical experience when they have not had the chance to have it. This obviously takes a little preparation, and then you need to make sure that your AV equipment is going to work. And for those of us who have taught TeamSTEPPS before, it's always the videos that go wrong. So they then had an opportunity to practice their skills using simulation. They were allowed, in this particular case, to self-select their roles. So in other words, a medical student could play a nurse if they wanted to, and a nursing student could play a physician if they wanted to. They had two parts to the simulation. One was resuscitating a trauma victim. And again, these people were very early in their careers. So the point was not at all the medical bits. It was the teamwork. And part two was managing the same patient after a sign-out, after they had been signed out to another team, but then the patient develops a heart attack. So an event occurs. They then had a structured debrief, and again, using TeamSTEPPS language. And as I stated, they then came back together for a large group session at the end of this to review sort of the major concepts for that particular day and review the learning objectives for that day. So again, what were the outcomes of this? About half the students responded to the surveys. These were not required surveys, and they were anonymous. Part of it was a knowledge test. Their knowledge did improve. They were also able to watch a video, and they had a sheet where they had to identify where they saw the skills being used, and they were able to do that. They were a little less able to recognize when a specific skill should have been used. And I think that's true for many of us who have either done coaching or observation. It is harder to find that missed opportunity than it is to find a skill being used. And that does argue for, this may not be a long enough period of time for the students to really develop a higher level skill like that. The nursing students' attitudes did increase. Sadly enough, and we can talk a lot about why this might be the case, the medical students' attitudes did not change. However, they were very satisfied with this. They liked it. They thought it should be done again. They especially liked the simulation. As many of you know who teach students very early in their careers, anything that you can do to put them in front of a patient, they absolutely adore. They really did go into their profession to help patients, and they're itching to get some real-world experience. So one more example, again in a slightly different setting, a little bit more senior students. So this is in more senior students who have clinical experience but aren't licensed yet. So they're not graduate medical education, they're not fellows, that sort of thing. And this is also in the interprofessional setting. This is a small pilot where medical, nursing, and pharmacy students from local schools, and it should be noted they were from different schools, because in this specific instance, there wasn't an academic health center. So there wasn't one place that had all of these students. So that meant the faculty had to go out and make friends with people from other schools. They participated in the seminar, focused on patient safety and TeamSTEPPS. Almost everybody at this point had had clinical or sort of ward training, so they'd had some real-life experience where they could hang this material onto. So I know there's lots of results on this page, on this slide. One was everybody's attitudes increased. Their attitudes were better. They liked working with each other more than they did before. Unfortunately, yet again, and this is proven over and over again, the medical students had less of a change than the other students. The pharmacy students felt more strongly that medical students that shared learning, would help. This is really about learning together, makes us work better together. The medical students felt they had to acquire more knowledge. So this comes back to sort of assumptions. The medical students felt like they were so busy learning facts that they didn't necessarily have time to learn attitudes or skills, which really speaks to some of the challenges in medical education right now. And it isn't a particular institution's problem to solve. This is a national problem. However, overall, it was very highly rated. 4.69 out of 5 is pretty highly rated for education. And the interesting part was they actually said that training with the other students was the most valuable part of the entire experience. It wasn't necessarily that they learned SBAR or that they learned CUS. It was that they were together. And that's another recurring theme in interprofessional education, is that students really don't spend time together unless we construct it that way. Again, those are just 3 specific ways that one might consider team training for learners. There was a systematic review from, again, this is medical student and resident. This was way back in 2008, so TeamSTEPPS was still pretty new on the scene. But there was this systematic review. 13 studies met the inclusion criteria. 77% included interprofessional, I would say, training. The term they used was multidisciplinary, which also tells you how quickly the language is changing for this. Their conclusions were, it appears to be modestly effective, but it may be most effective when it addresses principles, which I think, again, is one of the strengths of TeamSTEPPS, is that underneath it, there are principles there that the students can take away. So this is just a slide that summarizes how I've usually seen this taught or read about how this has been taught. And there are a couple different ways. So in the same way that you see a few different ways to implement in the clinical spheres, there tend to be 2 or 3 different ways. There tend to be 2 or 3 different ways that this is implemented in education. So in the preclinical setting, so students that really have very little or just a small amount of clinical training, usually it's in the classroom. And it's either a formal class or it's, a set-aside half-day, like in the one example, or part of a larger workshop, for example, getting them ready to go do their clinical work. It's with or without simulation, and whether or not simulation is used is often got to do with resources, as well as the sheer number of students involved. In the clinical years, you see it a couple different ways. One is, like in that first example, being part of that larger implementation. So the clinic is being trained, we've got some learners, we're going to get our learners in. The other option is the sort of set-aside time within the clinical rotation. So they have Wednesday afternoons for lectures. We're going to take one of those Wednesday afternoons and do TeamSTEPPS. Usually simulation is a little less commonly used in these examples, partly because of resources and partly because you have clinical experiences to draw upon. So these are some of the lessons for adjusting TeamSTEPPS for learners. this first one was incredibly important, and I actually hadn't realized how important it was when I first started teaching this. Students, especially the early students, not only do they not know their own roles, they certainly don't know each other's roles. And I would strongly consider spending time on this issue because they come to the table, as all of you know, with a whole set of assumptions. And those assumptions, if not dealt with, can really undermine the whole concept of teamwork and team training. So I would strongly consider spending a little time helping them learn about each other. Our medical students were amazed when they realized that our pharmacy students pay almost exactly the same tuition. And it's little things like that. Our pharmacy students were shocked when they realized that the medical students had 1 hour to learn all of the GI drugs, 1 hour of lecture. But it does kind of change your worldview of why you might need to help each other. The other lesson that I've certainly learned over and over again is that these learners, they're adult learners. That means they learn best in context, which means teaching this before they have any clinical experience is really tough. They also learn best when they think they need to know something. So if they think they need to use it tomorrow, they are a lot more interested in paying attention to you than if they don't think they need it for a year or two. They also really want to be involved in planning their own educational experiences. And some of the best examples of TeamSTEPPS have, involved interested learners in helping plan the education. And for the same reason that involving patients and quality improvement can be so powerful, I would strongly consider involving some interested students in planning the educational experience. The other thing that's terribly important is to know the clinical experience of your learners because, as you all know from going through these slides, the TeamSTEPPS slides have all sorts of acronyms in them that somebody who has no clinical experience, they won't know what to do with. You actually do need to go through the slides and make sure that the language is appropriate for the level of learner that you have. That also includes the exercises. Some of them need to be changed, some of them don't. That also includes the cases. Some of them need to be changed. You need to know the level of the learner that you're dealing with. The other thing I would stress, and this is true in education in general, is that less is more. Trying to get and cram all of those skills into a half-day workshop is not going to be nearly as effective as just trying to teach them closed-loop communication, and that's it. So less is more. They're already overwhelmed with everything they have to do. They're already freaked out. Also, you really need to consider the culture they will use this material within. You do not want to set these students up to fail. The worst thing that could happen is we teach them to cuss, and then they go out to a clinical experience, and they get in trouble for doing that. So, just remember, culture does eat strategy for lunch over and over again, and that a good debrief is worth 1,000 words. So most of us tend to teach this in an interprofessional setting. Doesn't mean it has to be done that way, but most of us tend to do that. But there are some real barriers to that, and anybody who's on the line who's worked in this area knows this. One of the biggest barriers in interprofessional education is overcoming these cultural silos that we have built. We don't know each other. We don't trust each other. And sometimes we don't value each other. And so overcoming that's really important. We also speak different languages to some extent. We use the word patient. We use the word client, all sorts of things that are different. There's a lot of history to overcome. And there's a lot of politics to overcome. There's always a question of when is the right time for them to learn together, and I don't think anybody has the answer to that. Some people say right away so they don't become enmeshed in their the current cultural problems we have. Some people say, you know what, they need to learn their own culture first before they can interact with others. I don't know that there's a right answer. One of the most just frustratingly crazy hard parts about interprofessional education and team training is managing the schedules. Anybody who's been on the call who's tried to set up a time for pharmacy, nursing, medicine, physio, etc. to sit together knows how hard it is. Space is a big issue. For example, all of our first-year academic health center students take a course together. There is one place on campus where they can go that has a big enough auditorium for them to sit. So if we can't get that auditorium, we're in big trouble. The other issue, as it was in one of the examples, is that, you know, some of our schools just have one profession within that school. So that means we've got to make friends with people from other schools who have that profession to offer. So that takes a little time. There also are certainly political challenges to this. And becoming friends takes time. I know many of you have heard me advocate for this book, but again, I'm going to advocate again. 5 Dysfunctions of a Team by Pat Lencioni, great book. There are also regulatory issues, you know, specific issues about who can control the students or grade students. When we started our teamwork course, you know, how we were going to get even course numbers was a big deal, whether or not somebody from the College of Pharmacy could give a medical student a grade. All those little issues had to be overcome. So however long you think it takes to plan something, double that time. And then, you know, you always need resources. You need people, you need things, you need time, you need help. This really stems from leadership's commitment to this work, just like it does for training frontline staff. So if leadership's not on board, that's the first thing that has to happen. So again, you know, our professionals, our students are going to practice in a world where this is expected and demanded. There are lots of ways to teach teamwork, but I think TeamSTEPPS is a great one. However, of course, I'm a little biased. There is an increasing evidence base for this within education and within the interprofessional education world. However, the material does require some basic adaptations, and you do need to spend a little time changing the material just a little bit for your learners. So these are just some of the citations, and these slides will be posted, so don't feel like you've got to scribble, scribble, scribble. These are some citations on using TeamSTEPPS in general, but also TeamSTEPPS within education. And you can see some are in trauma. There's one in the British Surgery Journal, and then there's that systematic review in 2008 is the last one on the slide as well. There are more citations than this. I just wanted to put a few up for you. So hopefully I've left enough time for questions and answers. Again, I really appreciate your time during the middle of a very busy day.
Thank you so very much, Karyn. That was great. I really appreciate the presentation. I would like to open it up to questions from the phone line. We don't have any in the discussion area, so if there's anybody that wants to ask Karyn a question verbally right now, Chantel will give instructions on how to do so.
Thank you very much. Ladies and gentlemen, at this time, if you would like to ask a question, you may press *1 on your touch-tone phone now.
And just, although there's nothing wrong with looking at this picture of 6 penguins lined up in a row, I'm going to advance to the next. Oh, sorry. While people, Chantel, are there any questions?
Yes, sir. We do have a question from
great.
Eric Buckland.
Great.
Yeah, is it Karyn? The question I have, and it may be to all, I was alarmed about the slides where it indicated that the med students' perception of the value or the impact of the training was substantially less than those of the pharmacy and the nursing students. And I find that troubling because attitude so often determines receptivity and retention. And I'm curious as to, did I interpret your comments correctly, and or what do you see as some of the keys of altering that so that when they get out practicing, they have a greater appreciation for the need for teamwork?
Thanks for the question. Yes, you did interpret it correctly. This is true around the world, so it's not a U.S. issue. And again, I'm a physician, so I'm going to kind of speak to my training too. But I think it has a lot to do with how we pick the people that go into medical school, as well as the messages that we give them at the very beginning. I remember my very first day of medical school, the anatomy professor gets up on the stage, we're all scared to death, gets up on the stage and says, you guys are fabulous, you're the best of the best of the best of the best, for those of you that saw Men in Black. And, you're about to embark on this journey that nobody else embarks on, etc. We're sending pretty strong messages to our students at that point. I don't think they're the messages that we really intend to send, but what they're hearing is they're a little better. So I think we need to really think about how we choose people, and frankly, Minnesota has changed significantly. I didn't go to medical school in Minnesota, but they have really changed how they're choosing students. And in fact, the entire country is actually working on incorporating within the way they choose students basically a team evaluation or assessment of how teamwork oriented they are. And actually, Dr. Eduardo Salas is involved in that.
Thank you.
Thank you. As a reminder, if you would like to ask a question, please press *1 on your touch-tone phone now. Well, speakers, at this time, it looks like we have no further questions in the queue.
Okay, well, I wanted to quickly bring up the fact that there are going to be a variety of IPE-related sessions during the course of the two-day national conference. Some of them will specifically have that as a actual focus and objective, and other ones of them have it sprinkled in. I know for certain that we have a coaching workshop that actually spends the first half hour before people begin working on their coaching skills, discussing the interprofessional education journey of the people who are presenting. And so there are going to be many different options. Discussing nurse residency programs, I know, is another session. So if you're interested in the topic and you haven't signed up for the conference yet, know that there will be some discussion about it there. I also have some questions here, and I realize that we're pretty much at the end of our time, but we just have some discussion questions here that we're going to go and put up on our main discussion, on the discussion forum at TeamSTEPPSPortal.org. And what these questions are for is that we'd love to keep this conversation going, and so if anybody would like to go over to the portal and drop in and answer these questions after you've had a chance to digest what's going on and what you heard today and think about your own situation, this would be a great place for people to continue the conversation. And this goes true also for anybody who's listening to this as a recording, because these questions will be up and you can come in at a later date, and we'll keep an eye on it to see these questions coming up. So at that point, I'd like to say thank you to everybody for attending today during your busy work day. I hope the weather is nice where you are, because looking out my window, it is raining and unfortunately cold here in Chicago. I'd like to thank Dr. Karyn Baum, who told me she has snow in Minnesota, so I don't feel that bad about myself. for her presentation and for all the work that she does for the TeamSTEPPS National Implementation.
And again, if people have questions, my email's on my initial slide, I believe.
It was, yes. Well, thank you very much, everybody. Have a wonderful day.
Thanks.
Thank you very much. Ladies and gentlemen, at this time, this conference is now concluded. You may disconnect your phone lines and have a great rest of the week. Thank you.